Dr. Vora, COPD is the second most common cause of death. I would like to understand first what is this disease about and how does it happen?
Asthma is a fully reversible disease, whereas COPD is not reversible. Not only that, it's a progressive disease.
The COPD develops typically in the middle age, elderly age. The symptoms are gradual in onset.
COPD is not only a lung disease. The understanding is it's more like a systemic disease now.
When they are smoking, what happens inside the body? What happens to the lungs? What is happening?
देखो अगर आप स्मोक करोगे हर धुआं कहीं से कुछ जलने से ही आता है तो वो आपकी लंग्स ही जल रही हैं.
A child who's just born would be exposed to this indoor pollution for years together, and it is obvious that he would develop COPD at much early age. तो child कभी smoking नहीं किया है, but he would develop COPD at 30 years and 40 years.
We were taught early, we realize it late. Let us realize it today that health is wealth.
Good morning, everyone. Welcome to Healthy Air with Zydus. In a country where millions of people struggle with respiratory challenges on a daily basis, COPD, chronic obstructive pulmonary disease, silently claims its place as India's second most deadliest non-communicable disease. And even after that, its impact remains vastly under-recognized in our national health. Today's discussion, titled How to Breathe Better Every Day, Understanding COPD and its Impact on Daily Life, brings together some of the finest minds in pulmonology and promises to transform complex medical jargons into simple language that could enhance and potentially save countless lives. We are privileged to have with us experts who have worked in the space of pulmonology in India and are spearheading with newer therapy management. I am honored to introduce and please welcome Dr. Bharat Gopal, Dr. Agam Vora and Dr. Prashant Chachar. Let's begin our discussion by understanding the second leading cause death in India, COPD. I would like to start with Dr. Agam. Dr. Vora, COPD is the second most common cause of death and due to non-communicable diseases in India. But yet the awareness or knowledge about this illness is still very less in the community. So, I would like to understand first what is this disease about and how does it happen?
Anona, I must thank you for organizing this program. COPD, yes, as you rightly said. In fact, I was just going through literature and we realized a couple of years ago, 3 million people died across the globe because of single disease COPD. If I make very rough calculation, that would mean probably by the end of this discussion, few people would die because of COPD in the country. That means 10 or 20 people would die by the time we finish this discussion. That common is COPD. And COPD not only leads to respiratory death, but COPD की वजह से मौत की वजह ब्रेन भी हो सकती है, हार्ट भी हो सकता है, सेप्सिस भी हो सकता है. That means the inflammation or the disease खाली लंग पे restricted नहीं होके पूरे बॉडी का डिजीज है जिसको हम सिस्टमिक डिजीज बोलते हैं. तो COPD की कॉमन वजह तो मल्टीपल है. लोग मानते हैं कि शायद स्मोकिंग एंड पोल्यूशन ही उसकी वजह है, पर देयर कुड बी वेरियस अदर फैक्टर्स. इट कुड बी जेनेटिक्स, इट कुड बी पुअर वेंटिलेशन इन द हाउस, इट कुड बी इंडोर पोल्यूशन एज वेल एज आउटडोर पोल्यूशन. तो ये सब वजह से COPD हो सकता है, स्पेशली इफ़ यू हैव अ जेनेटिक प्री डिस्पोजिशन टू डेवलप COPD. इन लोगों में ये ज़्यादा पाया जाता है. थैंक यू.
बट अगर मैं डॉक्टर भरत आपसे पूछूं तो इज COPD सेम और अ टाइप ऑफ अस्थमा व्हिच इज आल्सो कॉमनली नोन एज दमा?
So I think that's a very important question for not only for the general public, and you will be surprised to know that it's a very tough question even for trained doctors. आप ये देखेंगे कि lot of times patients who are diagnosed as asthma or COPD could be the other way around. So it's not very straightforward, number one. For a common man, हम जिस चीज़ को asthma मानते हैं, that is usually the allergic form. A disease which comes and goes. कोई उसको bronchitis कहता है, कोई उसको allergy कहता है, but that is the common understanding of a person कि ये allergy है, आएगी जाएगी, seasonal variations are there. But COPD differs from this. So as Dr. Vora rightly said, so it's a disease mainly because of the irritation. So irritant, it could be smoke, it could be pollutants, it could be any other form of occupational dust. All these can finally lead to the inflammation in the lungs which leads to COPD. Now, so this is different than the allergic component of asthma. So this is how these two would differ. Then they will differ in ages, they will differ in, as I said, in triggers, they will differ finally in treatment. So it's a two different types of obstructive respiratory diseases.
तो इफ आई may add to it, जनरली अस्थमा यंग लोगों में पाया जाता है. जनरली सीओपीडी या पोल्यूशन रिलेटेड, स्मोकिंग रिलेटेड डिजीज फोर्थ डिकेड, फिफ्थ डिकेड, 40-50 साल की उम्र में पाया जाता है. There are tests which can differentiate asthma from COPD. The biggest message that asthma is a fully reversible disease, whereas COPD is not reversible. Not only that, it's a progressive disease. In the sense, आप देखते हो वो child who may eat something or may go to a garden and may get sudden attack of asthma. He takes his inhaler, he takes his medicine, and he could be completely fine. Against that, you have a COPD patient who's not going to be completely fine. The message for society is, yes, COPD and asthma can have overlapping symptoms, but by and large, COPD is a irreversible disease. COPD is a progressive disease.
So just to take this forward, I would like to again take this opportunity to again bring up this point of asthma, that people with asthma who are listening to this podcast should realize that asthma is reversible. You can live a normal life, you can maintain a normal lung function or a near normal lung function through your life. And that's different in case of COPD. But if you don't take optimal treatment with asthma as directed by physician, if the symptoms are not well controlled, if your lung function is not maintained optimally, then you are also at risk of progressing eventually to COPD.
Okay. Yeah. But how can people identify the risk? If I ask you, continuing to this session only.
So as was also discussed a little bit, touched upon by Bharat and also by Agam, I think first we need to understand what are the risk factors that lead to COPD. One, as Agam said, for asthma, typically you may have an allergic, you may have an early onset. For COPD, the most common cause of COPD worldwide is smoking. Tobacco smoking is the most common cause. Then, of course, that's a direct smoking. Then you have passive smoking, but these are not limited. Also in India, we have identified, there's a lot of work done in Pune also and published in very reputed journals, that you can have non-smoking COPD also. That is also very common in India, and that is because of chula fume exposures. So if people are cooking on the chulas, if the places are not well ventilated, that is also a risk factor. The other big risk factor for COPD is air pollution. Air pollution, all these pollutants, they almost behave in the same manner as cigarette smoke would behave. Then you have at workplace, you have chemicals exposures, irritants at workplace, which may eventually over a period of time trigger into a COPD.
So can I add a couple of things? I think both of my colleagues would agree, there's a very different type of COPD which we see in India rather than the Western world, which is the COPD secondary to tuberculosis. And now, in fact, newer guidelines have internationally put post-infective COPD also. So, as doctors who have been in this profession for more than 2 decades, we used to see a lot of tuberculosis patients whom we would cure, right? Because there's a proper program running from the government. But they would keep coming back with breathlessnesses, and these are patients who had not smoked. And now the world has realized that that's a different subgroup, which probably we have more in India because of the type of population, poverty, and all those factors which lead to more TB. And that can also precipitate. And also, again, reiterating what Prashant said, that people who have asthma and don't get treated properly, they would somehow go into a remodeling, which would be then behaving as COPD. So they would add on to your common smoking, which is almost sine qua non with COPD, right?
I got chance to travel across the country, and in many rural India, you would see the houses with poor ventilation. You would see there are no good cooking facilities. They would use all possible things for cooking. So you have right from cow's dung to animal products to plant products, etc. for cooking. Now it requires energy to light fire. And in that case, they would maintain that fire throughout the day. You can imagine a small house having poor ventilation where this fire is lit almost 24 hours, leading to so much of indoor pollution. And on top of that, if you have a senior member in the family who's, say, homebound or is not much active but is a smoker, you can imagine the risk a newborn child in the family would have. And that is the importance we are understanding nowadays of something called as particulate matter. Particulate matter of 2.5, if you have heard about it. These particles would remain in the air for a longer time. A child who's just born would be exposed to this indoor pollution for years together, and it is obvious that he would develop COPD at much early age. तो child कभी smoking नहीं किया है, but he would develop COPD at 30 years and 40 years.
Because of the external
Yes,
factors.
so what we were looking at when I was student, Prashant was my teacher, and Prashant taught me that COPD 50 साल के बाद में होता है. But now we have both come to realize that we are seeing COPD at least a decade earlier than our Western counterparts. क्यों? क्योंकि शायद हमारे कंट्री में पोल्यूशन लेवल ज़्यादा है, शायद हम ये इंडोर पोल्यूशन को इतनी अच्छी तरह से समझ नहीं पाए या टैकल नहीं कर पाए, जिसकी वजह से COPD देखा जाता है.
ओके बट उसमें सर अगर मैं आपसे पूछूं, वी ऑलवेज कीप सीइंग कि अहमदाबाद वो एज इन बॉम्बे, बैंगलोर, दिल्ली, दीज सिटीज आर लाइक most of the polluted cities in India. So in that case, what is happening to their lungs?
I think it's like we are smoking the air pollution. I think it's almost equivalent to that. And just to convey to the audience, so I think it's very clear whichever city, whatever city wherever there is pollution, you could have pollution in the metros. You can have pollution even in industrial areas. You can have pollution in industries which are having a lot of, which are creating a lot of pollution also. So any individual who is exposed to this would come under the category of a non-smoking COPD. That is just to differentiate that the smoking COPD, we talk about tobacco smoking, and the non-smoking COPD, we discussed all the various aspects. An individual really has to understand that when we talk about non-smoking COPD, I think all the factors which all the panelists have discussed here today should be recognized. You've got a summary of very important points which are being put across to you, that please take care of the ventilation, please take care of measures to reduce indoor pollution. If there are people running campaigns, we should also spread awareness on how these, what is in our hands. One is reducing indoor pollution, and plus, of course, overall, at a larger scale, reducing pollution in metro cities and overall in the country per se.
But anything specific that you would suggest that, should be done, because they're living, they're breathing that air. So that can't be avoided, right?
Yeah. So I mean, the question, yeah, that's a very good point. So, if somebody has already COPD, there is increased pollution in the air, what do you do? Okay, how do you, so if somebody is going for a walk, we tell them if you're going out for a walk, you go out for a walk when the sun has come out. Because when the sun comes out, when the temperature increases, the pollutants rise, and to a certain extent, the amount of pollutants at the sea level or wherever we are staying would become less. So we ask people not to do early morning walks or to do walks when it's too cold. Yeah, so you do it in warm areas. And I mean, if some people have too much of a problem, pollutant levels are high. If you've got a big mall next to your door, it's, you could go to a mall and take a walk. But it's important to exercise. So these are some of the tricks we give patients. Another important thing is masks. I think the use of mask, before COVID was looked down upon. But now I think it's been well accepted that masks can be worn not only to prevent you from infection, but can also help you to prevent from pollution. So if an individual has COPD, is living in a polluted area, then yes, you can use masks and you can go out. And lastly, if you are working in an environment where you are exposed to pollution, then there are N95 masks, N99 masks. So as deemed appropriate, you can also use the masks. There are many things such as, air purifiers, etc., etc. I think they sound very good, that in a particular room, if the individual is staying there for a long time, next to a polluted, next to a very busy street, the air purifiers may help. But we still don't have strong data to suggest these expensive air purifiers on a regular basis.
To my mind, pure air is just in concept. There is nothing called as pure air. Where is the pure air? You are talking about air pollution in Mumbai only, or Ahmedabad only, or Delhi only, or metro. You said no. Entire country, entire world, entire globe has polluted air. You go to rural area, the pollutants could be different. There could be probably more of pollens, and there could be more of farming related pollutants. You go to probably heights, and there could be probably the particulate matter could be different. But then pure air is only in concept. It's not there in reality. So I have come to believe that if you are breathing, you are at a risk of developing COPD. It's that common. And yes, what Prashant said, and when you are asking about what can be done, A lot can be done. It can be done at individual level, it can be done at society level, it could be done at a national level, it could be done at a policy level, it could be done at your and my level. What we are doing is we are trying to create awareness about COPD and air pollution. As Prasant said, one could wear mask and prevent himself. It's about, if you light just one cigarette less, not only you're preventing yourself from developing COPD or worsening of your COPD, you're helping your family. They will not be developing COPD. You're helping society. The air pollution levels would be less. If you just decide to travel once without taking your car, दिन में अगर एक बार आप साइकिल पे जाओ, दिन में अगर एक डिस्टेंस आप वॉक करके करो, yes, it's your contribution to country. As a citizen, this is, yes, you can do that. अगर आप एक ट्री को न काटो या एक ट्री को प्लांट करो, that's your contribution to probably improving air quality, right? I think we can do lots.
Yeah, and that needs to be thought about.
Basically, it's a multi-stakeholder issue now, because we'll, as a person from Delhi, next month or so is going to be
Tough
we
time.
dread post Diwali. So it's going to be smog, and so this is what we keep telling, that it's a multi-stakeholder. The whole politician bias is there. But I think whatever we can do at each and every individual level, each stakeholder has to be now involved, because it's not only that pollution for those short-term effect, but COPD is a definite long-term effect of those pollution which we are suffering. And that's what we are seeing in Delhi now, the numbers.
I'm sure, but the question is, why the awareness is not there? I want to ask you, sir. I mean, why no people are talking about it even now?
So, I think in general, the awareness about diseases in our country is low. That is the one problem. I think, I don't know how many, in the early schooling has health-related subjects, right? I know that when we were probably students, we used to have moral science as a subject. So I don't think even that exists now. So because the way society is, probably they don't need now moral science to be taught. But I think I believe that it has to start from very young. The child has to be taught that there's a value of health, and there is a value of knowing about basic concepts of health, right? Number one. So awareness, biggest problem is that we are, as a societal problem, we are not prone to actually learning about this. I think more or less the health awareness, including for COPD, is taken from social media. Now that could be right or wrong, but a lot of it. So what we are doing is a step towards giving proper awareness regarding this disease. The third is that probably the disease as such, as we started right in the beginning, is probably mixed up with so many other respiratory diseases that it lost. I'll just quickly tell you, in 2019, there was a study where they actually looked at data from 2004 to 18 from Google hits of COPD. So the amount of problem which is there, they found that the hits for COPD as a terminology was hardly any. Right. Definitely there is a change in the respiratory disease awareness post-COVID. There is no doubt. But if you look at data, it's still quite low, but I think the awareness is increasing, but the problems will still remain. There's a lot of work which needs to be done to make the general public aware that COPD as a disease definitely exists and is an important part.
I'm sure if we see in the public also, most of the disease related to lung, people know is either pneumonia or asthma. I think these are the two major diseases.
Problem is at multiple levels. Somehow, COPD comes with little advanced age, and hence people feel that itna to hota hai. People have kind of accepted this disease. This disease is very gradual in its onset. It's not like your chest pain suddenly and you have fear of about heart disease. Disease comes up slowly, and hence people tend to accept it. As Bharat said, the symptoms are really overlapping. So then you will see COPD patients having 10 ECGs, done 2 echoes, have been to 4 cardiologists, but may not have consulted a chest physician because they feel it is heart related. Certain specialities, for example, society has done very well when they have come to realize about heart disease. Cardiologists have done an excellent job in creating awareness about heart. It is chest physicians. I am to be blamed because we could not really go out to public to create awareness about COPD. Would you believe that COPD does not have a local name? When you talk about asthma, people know about Dama. When it comes to COPD, there is no local name. People would call it as Dama, Kala Dama or whatever. So it is still that. Second thing is, somehow You also never created any awareness about it. We are also meeting here for the first time. So you are to be blamed. I am to be blamed. Society is to be blamed. Symptoms to be blamed. Last thing is, a lot of people felt that COPD is because of smoking. And they feel, हाँ ये तो अबे इतना cigarette पिया तो COPD तो होना है. And the kind of acceptance they have. One more thing, about a decade and a half now, we've got fantastic drugs available for COPD. Before that, we did not have enough treatment available for COPD. Even after diagnosing, we were not able to offer any Herculean treatment or real solid treatment to COPD patients. That was one more reason about not having adequate awareness of COPD. But now we are at definite better stage. We've got fantastic drugs available. We've got fantastic awareness about disease available. We've got fantastic investigations available. We can pick up COPD at a very early stage. We can offer them treatment at a very early stage. And with that, the life course could change. They could live absolutely normal life.
Got it. So, Dr. Prashant, if I ask you, like we spoke about the test, so what are the tests to be done? How can a person know about their lung quality?
Yeah, so taking exactly from where Agam left, he touched upon the investigations. So what Agam was also trying to put across is that if somebody has a symptom, there's a commonality of symptoms. You could an elderly individual or a middle-aged individual, whenever that individual starts to get breathlessness, थोड़ा दम लगता है, थोड़ा जल्दी थक जाते हैं, the first thing you think is about a cardiac. Yeah, so you do ECGs, you do echoes, which is fine. I mean, we do see the young people getting cardiac problems. That's absolutely fine. The point is, you need to include a very simple test also. You need to start thinking about, if you want to think about COPD or if you want to think about lung assessment, the simple test is a lung function test, a spirometry. Okay, a spirometry which is done very simply over a 10-15 minute period, and then you get to understand what your lung function is. Of course, there are further tests also. You have a complete spirometry, you have diffusion capacities, you have body volumes, but I think let's leave that to the specialist. If you see for this World COPD Day also, the theme is get to know your lung function. Do your lung function test. Where does your lung function stand? That is the theme. So I think it's a very important theme, even which the global initiative for chronic obstructive lung diseases has also picked up. And I think it's a good opportunity for us to promote a simple test called PFT or the spirometry. That test will allow us to detect COPD early. The reason being, as he said, the COPD develops typically in the middle age, elderly age. The symptoms are gradual in onset.
Can you talk about the symptoms also?
Yes. So I'll tell you the symptoms. So the typical symptoms, how does a COPD individual, what's the typical journey? These individuals start to get symptoms of cough. They can get repeated bouts of cough. They're typically treated for a sore throat, upper respiratory infections. But in an individual who is smoking or is living in a polluted environment, if the cough is not getting settled down, then you must start thinking about COPD. That because cough, a persistent repeated cough could be one of the symptoms of COPD. The other thing is breathlessness. Now, as Agam said, typically develops an individual who are middle age or elderly, and if they get tired early, they feel, oh, that's a part of age. No, I think if an individual is getting that, one must start, when you do your cardiac tests also, you must also think about doing your pulmonary test also. So typically cough and breathlessness are the typical symptoms. Another thing, what happens is people get repeated respiratory infections. So people are taking multiple courses of antibiotics. Okay, but antibiotic लेते हैं 2 महीने बाद वापस लेते हैं. So in individual with COPD, you are at an increased risk of getting infections. And what these infections also do is, these infections also cause a flare-up of the COPD. So again, typically they come to us with increased infections. So these are the typical ways they come to us. Often we see patients are coming admitted. वो एडमिट हो जाते हैं, पता चलता है कि अरे दे ऑलरेडी द लंग फंक्शंस कॉम्प्रोमाइज्ड. यू टेक द हिस्ट्री, दे हैव एडमिटेड विद अ लोअर रेस्पिरेटरी इन्फेक्शन और निमोनिया, एंड व्हेन यू लुक एट द हिस्ट्री एंड यू आस्क देम इन डिटेल, जैसे हाँ साहब थोड़ा 1 साल से थोड़ा सा सांस की तकलीफ बढ़ रही है, पहले हम 3 माला चढ़ पाते थे, अभी हम 1 माला चढ़ने में भी दिक्कत हो जाती है. सो दीज आर द क्लूज विच हैव टू बी टेकन. सो व्हाट आई वुड लाइक टू पुट अक्रॉस टू द पीपल एट लार्ज इज, इफ यू फील दैट योर ability to exert is becoming less, if your effort tolerance is becoming less, if you have a cough which is not settling down, you must think about getting investigated for a respiratory problem. Not necessarily that could be COPD, it could be an infection such as tuberculosis also.
Okay, but Dr. Bharat, if I ask you, how often, like you mentioned, should we consider LFT also as a preventive test? Like we should be doing it every 6 months, how should be done?
So in a utopian state, we should, but it's difficult. So the thing is, couple of things I'll just add on, and then we discuss about this. So, funnily, what I think in the initial part we just Agam just touched, COPD is not only a lung disease. The understanding is it's more like a systemic disease now. So there are people who would come to you with they've smoked, they have reduced exercise capacity, so they themselves start reducing walk and stuff, and they have these muscle weaknesses, what we call as sarcopenia. A lot of patients we have seen, they're actually admitted for weight loss, fatigue, right? Symptoms which are actually, and when you look at it, like he said, you would see the lung function is probably 20% of the predicted for his age. And it has reached, and then they will say, yes, we have been doing, then I could not walk, so I have stopped walking. So obviously, when you stop walking, you will be having other issues. So we'll leave that discussion for probably a later time in the show. But so you could have non-respiratory symptoms of COPD also, like we have non-smoking COPD, we have COPD which have symptoms apart from respiratory system also, one. Secondly, you said about the lung function, how often. Now the thing is, the idea is about early detection. Now early detection could be the detection at an early age, or it could be detection at an early phase of the disease. So there are two different parts altogether. Now, there is definitely no guideline which says that you start looking at lung function of the community. The guidelines are that if somebody is smoking, has symptoms, you definitely do a lung function, right? You should, to rule out COPD. But if you look at the studies or the research, they say that if you have people who smoke or are at risk factors, any other risk factor, and you are able to do lung functions and pick up those diseases at maybe a very early stage, I'll not go into the technical jargon, but maybe at a very early stage, you can actually reduce the incidence in up to 50% of people in 5 years. Or to look at the flip side, if you don't do anything, 50% of those patients would develop COPD in next 5 years. So if you look both it's the way half full or half, if you start detecting these patients, and if you look at, there are studies in the communities that where they have actually for research purposes started looking at subgroups and who are say non-smokers, maybe in communities, and looking at those studies, and they have found that there could be an incidence of early COPD even in those subgroups, which may be even 10% or 15% because of the environmental issues, indoor issues. There's so many different non-smoking, because we have for last so many years as medical community, as social awareness campaigns, we have stuck on this thing that it is COPD is a smoker's disease. Yeah. It is not. I think one take-home point from this podcast should be that let's start creating the awareness that COPD could be in non-smokers also. Because then we miss a very large chunk of patients who are then probably not treated optimally because we are thinking of another disease. Right?
Yeah.
So if I am to add to what you're saying, I would say, as you do your regular health checkups, spirometry should be a part of it. So you have lot of annual checkups happening. I believe anybody who's got cough, sputum production, and breathlessness must undergo one PFT for sure. If that PFT is abnormal, they must consult physicians, chest physicians, and should be put on treatment accordingly. If it is normal, they should do it once a year for sure. Anybody who's working in those kind of environment must do their PFT. Everybody who feels that they are in little polluted area, से मेरे बाजू में कोई इंडस्ट्री है, मेरे नीचे बहुत pollutions है, traffic congestions है, etc. If there are a lot of color गया आपके घर का, there's a lot of renovation or the repair works going on around your area, all these patients, all these people must do their spirometry at least once a year. That's what I feel.
But if I ask you, people who went through probably 2 or 3 times they had COVID or anything, how has that changed? How has that increased the...
You know that God has given, lung is the largest organ. Do you know that lung is this big? Heart कितना है? Brain कितना है? And that too double. You know that एक kidney चली गई आपकी, you can live normal life. एक आँख चली गई आपकी, you can live normal life. एक लंग आपका निकल गया, you can live normal life. तो भगवान ने इतना बड़ा रिजर्व दिया है. इसीलिए most of us do not realize, even if your lung functions are compromised to 50% of your expected capacity, so people are hardly symptomatic. if their lung function drop by 20, 25, 30%. And that's the reason they don't really realize about their compromised lung function. This can be picked up only if you do spirometry.
So can I add to that COPD, the COVID, because I happened to write a chapter, so I had to review this for a textbook which is soon to be published. So definitely there has been an incidence of increased obstructive airway disease in post-severe COVID. So there is a definite incidence which has increased in this subgroup as compared to, say, other pneumonias or other lung infections. So we can only compare like to like. So this infection, which was COVID, versus the others, even despite treatment after 2-3 years, there is a subgroup of patients who has decreased lung functions. So,
and it depends on the extent.
Yeah, so that's mostly severe ones, mostly the ones who had severe COVID.
So we remember that time they were scoring, 20%, 25%, 30%. The more the lung involvement, more are the chances of having
residual
long-term
disease
complications
remaining.
But okay, Dr. Prashant, I want to ask you here then. Suppose our patient got COPD now. So what happens? Can you describe the journey? What happens if a person gets COPD?
Sure. So it's like you're referring to a patient journey. But just before that, I would just like to add one thing, So there is we discussed that lung function has to be done, and, people with symptoms should do it, a health checkup should do it. But I think there is an opportunity. Often what happens is any individual who has a heart problem, who has a diabetes problem, who has a kidney problem, who has a blood pressure problem, often these individuals will go and get some tests done. I think it is worthwhile that one of the times you should also add a lung function test, because it's an opportunity to you're already there, you're already at the lab, you're already at the diagnostic center, you're already at the hospital. Just add a lung function test, and I think it's just something which is simply done. Yeah. So now coming to your point, what is the journey of a typical patient who has COPD? As was discussed earlier, COPD is a non-reversible disease. Okay. And typically it is a progressive disease. What we need to do is that, we speak about why should we speak about early diagnosis and treatment and all? Because if you make an early diagnosis, then there are two things you can do. One thing you could do is you can try to stop the smoking or stop the triggering factor. And secondly, you can start treatments which can give symptomatic relief and slow down the progress. You can start taking preventive measures to reduce infections, vaccinations, etc. So I think that is the point of early diagnosis. So typically it is a progressive disease. We want to intervene to slow down the progress and to reduce the risks for the patient. So typically, as I said, these individuals would come with a cough. They would come with a breathlessness, then you would treat them. Often we typically get most of the patients in a moderate to a severe disease for various reasons. Once these people are initiated on treatment, we have several individuals. Now with the current therapies, we can achieve a good amount of stability. With a multi-modality approach. It's just not inhalers, but you would give them inhalers, you would give them vaccinations, you would take care of their nutrition, you would take care of their exercise, and then you could maintain a good, stable state. Now, there are some individuals, despite all the efforts, you can still get flare-ups. And that's the problem. It's called a flare-up or an exacerbation of the bronchitis. So as the bronchitis, as the journey goes ahead, as the age progresses, the individual will always be at an increased risk of a flare-up. And unfortunately, whenever you get a flare-up and you recover from the flare-up with the treatment, you may not go back to the same lung function as you had before the flare-up. So typically, then the lung function starts to go down. So individuals who get more and more flare-ups, the lung function starts to go down and down. If the flare-up is severe, or if this COPD is severe, progressive over a period of time, then what happens is that people start getting restricted in their day-to-day activities. Like what Oli mentioned, initially they think it is because of age, but then restricting in your activities happens. Your oxygen levels can start to go down. You may need oxygen supplementation. In individuals who have a severe COPD, you can have carbon levels which can go up. Then you may need non-invasive ventilation at home. So point is, in a patient with COPD, it can start with a cough, breathlessness. Both these symptoms can increase with time. Your effort tolerance can also reduce. And also alluded to, COPD is a systemic disease. Along with the COPD, these individuals are at an increased risk of cardiac disease, blood pressure, stroke, etc. And these comorbidities also start to affect the particular individual. So typically we will see an individual with COPD will progress over a period of time. Our interventions, we want to slow it down. But as this individual progresses, he might be attracting or be diagnosed with other problems also.
Okay, but does this has a stage, like we say na ki you have reached to this stage in a disease?
Yes. So there are two ways of looking at it. You can call a stage 1, stage 2, stage 3, stage 4 based on your objective classifications. बराबर है. These objective classifications are useful for physicians to say in which class this individual fits, and then we can choose appropriate therapies. बराबर है. If individual has a severe COPD, and if you look at the data 10 years ago, not now, not after the newer therapies have been implemented, an individual who has a lung function capacity FE1 of less than 50%, a severe COPD, could potentially have a survival of only 2 to 4 years. But these are data, epidemiological data from about 10 years ago. We are still waiting for newer data to come in to see whether the newer medications and a multi-modality treatment or a multi-specialty approach to a COPD patient has helped also in the outcomes and the survival.
But okay, so Dr. Vora, I would like to add on this and ask you, so if there is a newly diagnosed patient now, how they can improve the outcomes?
So newly diagnosed patient could mean at what stage you are diagnosing them. So there could be a patient whom you have diagnosed at a very early stage. See, ये पेशेंट शायद तुम्हारा कोई हेल्थ चेकअप करने गया और उसमें उनके पीएफटी के ऊपर पता चला कि they've got lung. He is not symptomatic. The course could be completely different. Vis-a-vis, you have a patient who's newly diagnosed but is severely symptomatic. That means he already had breathlessness for so many years. He already had cough for so many years. He got his X-rays done, rest everything done, but spirometry is doing now and is seeing probably Prashant or Gopal for the first time and being diagnosed as COPD for the first time, but he is at advanced stage. तो सपोज अगर कोई पेशेंट को मैंने बहुत अर्ली स्टेज में फाइंड आउट किया है जिसको ज़्यादा सिम्टम नहीं है, एंड इफ ही फॉलोज योर ट्रीटमेंट प्लान, ही विल लिव एब्सोल्युटली नॉर्मल लाइफ, he will have no complications. Most of the time the disease will not progress provided we are able to take care of all his risk factors and change his lifestyles. तो अगर वो स्मोकिंग छोड़ देता है, अगर वो अपने ऑक्यूपेशन का ध्यान रखता है, अगर वो पल्मोनरी एक्सरसाइज रेगुलरली करता है, अगर वो अपनी ट्रीटमेंट जिस तरह दी गई उस तरह फॉलो करता है, वो एब्सोल्युटली असिम्प्टोमेटिक लाइफ जी सकता है. Vis-a-vis, if you have a patient who's really advanced COPD, this patient will always be symptomatic. वो कभी नॉर्मल नहीं हो सकता. उसके लंग फंक्शन को मैं 10, 15, 20% इम्प्रूव कर सकता हूँ, बट ये आगे इम्प्रूवमेंट नहीं होगी. बट डिजीज़ कैन बी अरेस्टेड एट दैट स्टेज, इन द सेंस डिजीज़ को आगे बढ़ने से मैं फॉर श्योर रोक सकता हूँ. उनको जो नंबर ऑफ एग्जैसिबेशन, नंबर ऑफ हॉस्पिटलाइजेशन होने वाले, forget that. I'll tell you a story of my mama, my own uncle. We lost him 2 years ago. Before that, 127 days he spent in the hospital out of 365 days a year. That is the story. They get exacerbation, they are put on treatment, they go home, repeat exacerbation, again they are in the hospital. You can imagine more than 1/3 of his life he spent in hospital. So this is the story of a COPD patient. In spite of being on best treatment. And जैसे डिजीज आपका एडवांस होता है, डिजीज ना ही सिर्फ लंग में होके पूरे सिस्टम में है, it will give you multiple complications. All those patients who are seeing with oxygen connected may have underlying COPD, जिसको हम respiratory failure बोलते हैं. तो COPD progresses to respiratory failure, and these patients are home-bound, chair-bound, room-bound. They have to continue move with oxygen. Luckily now we have got better machines available. I'm sure हमारे सबके पास ऐसे patients हैं जो OPD में ऑक्सीजन का सिलेंडर लेके आते हैं, तो that is the story. So your patient could live completely normal life. Your patient can have better quality life. Vis-a-vis, they can continue to suffer. So that's the whole story of COPD patients. They get multiple exacerbation. ठीक होते हैं, exacerbation ठीक होते हैं, लेकिन उनके लंग फंक्शन कभी नॉर्मल नहीं होते, एंड ओवर टाइम दे वुड डेवलप. तो रेस्पिरेटरी फेलियर में क्या होता है, शुरुआत में ऑक्सीजन कम होने लगता है, देन कार्बन डाइऑक्साइड बढ़ने लगता है, एंड देन कार्बन डाइऑक्साइड बढ़ने की वजह से उनके बॉडी में डीकॉम्पेंसेशन चालू होता है जो बर्दाश्त नहीं कर पाता है बॉडी. तो आफ्टर सर्टन लेवल यू कैन इमेजिन टू मेंटेन दैट ऑक्सीजनेशन यू आर ब्रीदिंग सो हैवी. तो आप कई बार चेक करते हो, अरे मेरा ऑक्सीजन सेचुरेशन 92 है, अच्छा है, लेकिन 92 ऑक्सीजन सेचुरेशन मेंटेन करने के लिए भरत भाई अगर 10 बार सांस लेते हैं, मैं 25 बार सांस लेता हूँ, एंड दैट लीड्स टू लॉट ऑफ वर्क ऑफ ब्रीदिंग, दैट पुट्स मी एट फटीग. आई कैन टॉक, ट्राई टॉकिंग. आप सांस लेते लेते बोलने की कोशिश करो, हाउ मच ऑफ एफर्ट यू रिक्वायर. तो ये सस्टेन नहीं कर पाता आदमी, एंड देन दे गो इनटू डीकॉम्पेंसेशन, यू लूज देम. तो दैट द स्टोरी. एंड कई बार एज ए चेस्ट फिजिशियन आईसीयू प्रैक्टिस करते हुए हमने देखा है. सी हार्ट का पेशेंट कई बार एक झटका एंड यू नो यू लूज देम. वी आर सॉरी फॉर दैट, वी आर सेंसिटिव फॉर दैट, बट इमेजिन रेस्पिरेटरी डेथ. You suffer and then you lose your life. Not only you suffer, entire family suffers. Imagine to see somebody in your house breathing like this for days together, months together on oxygen is not easy, and it is manageable. Now it is manageable. You've got fantastic treatment when probably you can change the outcast. That's the purpose of this meeting. Thanks.
The most important reason that you mentioned is smoking is one of the major cause. So I would like to ask you, Dr. Bharat, smoking, because this is very important, बहुत basic question है, but people need to understand when they are smoking, what happens inside the body, what happens to the lungs, what is happening. So if they have a technical picture, they will know.
तो आई थिंक उसके लिए सबसे आसान तरीका जो है वो द वे वी टेल आवर पेशेंट्स और आई कि देखो अगर आप स्मोक करोगे हर धुआं कहीं से कुछ जलने से ही आता है, तो वो आपकी लंग्स ही जल रही हैं. तो ये बात समझानी ज़्यादा आसान है. अब आप टेक्निकल में जाओ तो ऑब्वियसली हाउ इट इन्फ्लेम्स योर म्यूकोजा, हाउ द सीलिया, तो हमारे लंग्स के अंदर जो होते हैं उसमें छोटे छोटे बाल हैं, आप सोचो, जो थप थप करके म्यूकस को बाहर निकालते हैं. दे गेट किल्ड, ठीक है, they are destroyed. So the mucus keeps getting produced, it cannot be cleared. The lungs will keep getting filled up. So these are people who would call, जैसे बता रहे हैं कि वो पूरी जोर जोर की सांस लेंगे, खांसने की कोशिश करेंगे कि हम बाहर निकालें. But so आप you would have heard of a term called smokers cough, right? So people think there is something called a smokers cough कि मैं कर रहा हूँ, मेरा गले में ये सिगरेट का धुआं लग रहा है तो मुझे खांसी हो रही है. They don't understand it's probably that cough originating is from the lungs only. So I think because of the type of show we are having, it is difficult to probably just describe how it's a whole probably chapter in itself, and how the nicotine actually, burnt nicotine rather, actually goes and destroys various functions of the lungs. But simple thing is कि it does destroy, it will destroy. So there is nothing like less smoking. There is nothing like कि मैं थोड़ी कर देता हूँ, ठीक है, मैं आधी तोड़ के पी लेता हूँ. प्लीज़ फॉर एवरीबडी हु इज़, अगर आप ये एक चीज़ इन अनु के शो से आप ये सीख लेंगे कि आप आज के बाद स्मोकिंग छोड़ दीजिए. इट मे बी डिफ़िकल्ट, यू मे नीड प्रोफेशनल हेल्प फॉर दैट, बट इट इज़ 100% पॉसिबल. डोंट थिंक इट इज़ मिशन इम्पॉसिबल, इट इज़ पॉसिबल.
Can develop any habit at any time and we can quit any habit at any time. I'm sure आपके भी कोई भी रिलेटिव अगर आईसीयू में एडमिट है, हाउएवर क्रॉनिक स्मोकर, अल्कोहलिक ही में भी, आईसीयू में वो कुछ नहीं बोलता है, चुपचाप. मुझे कोई आईसीयू में नहीं पूछता एक बीड़ी पीऊँ क्या, एक सिगरेट पीऊँ क्या, एक पैग मिलेगा क्या. द मिनट यू टेल देम कल हम आपको शिफ्ट करने वाले, उसका अरे यार आई एम अ विनर, यू नो, मुझे कुछ नहीं हो सकता, मैं तो इसमें से निकल जाऊँगा. बाहर आते पूछता है अभी एक अर्धी पीऊँ क्या, यू नो, दैट इज हाउ इट स्टार्ट्स. तो देन व्हाट मेक्स मी फील दैट कि ये आप छोड़ सकते हो, ऐसा नहीं कि नहीं छोड़ सकते हो. यू नो, इट्स सोशल प्रेशर, इट्स योर, यू नो, एक स्मोकर का एक एनवायरनमेंट बन जाता है. मुझे मेरा एक दोस्त मिलता है तो मन करता है चल ना एक जला ले, यू नो, दिस आर दी डेली एक, हाँ, और उसमें से निकलना मुश्किल है. तो स्मोकिंग छोड़ने के लिए ना खाली पेशेंट को तैयार होना है, पूरी सोसाइटी को तैयार होना है. इफ़ यू वांट अ स्मोकर टू क्विट स्मोकिंग, इट्स नॉट ओनली हिज विल, उसका फैमिली अगर, उसके फ्रेंड सर्कल, उसके सोशल सर्कल अगर उसमें इन्वॉल्व नहीं होते, वो कभी छोड़ नहीं पाएगा.
True, very true.
Yeah, one of the important points I want to highlight is that we referred to indoor pollution, and one of the factors for indoor pollution can be incense sticks, can be dhoop, can be the mosquito coils in a non-ventilated area. So one has to be very careful, particularly if you are having any respiratory problem. That can be a big trigger.
दिवाली पूजा, दिवाली में हाउस क्लीनिंग, अरे पूरा बिल्डिंग हाउस क्लीनिंग. इमेजिन देयर इज अ सीओपीडी पेशेंट बोलता मेरे घर में मैं सफाई नहीं करता, बट बाजू वाले का क्या, पूरा बिल्डिंग व्हेन दे डू हाउस क्लीनिंग इन दैट पर्टिकुलर 4-5 days, environment is.
So I'll tell you a small story. So very early in phase of my practice, so one pujari came to me and we did the lung function and everything was almost on par with COPD. अब मेरी तो हिम्मत ना हो पूछने की कि पुजारी जी आप सिगरेट बीड़ी पीते हो, ठीक है, कहीं हमें लगे वो उस टाइप के पुजारी की जो होते हैं ना, कुछ लोग भाई चिलम वाले, वो वाले भी नहीं. सो अब कोई somebody had taken है वो, आई यूज्ड टू फील वेरी स्ट्रेंज कि वाई. एंड देन ग्रेजुअली ऑन द सेकंड थर्ड मीटिंग आई रियलाइज्ड विद दिस गाय ही यूज्ड टू डू दैट ऑल दैट हवन विद ऑल सॉर्ट ऑफ सामग्री एंड ही हैज बीन डूइंग इट फॉर लास्ट 30 years. So Obviously, that is this. I'm talking about 2004. So 20. So yeah. So it needs to be understood. If we do see, because as a society we are usually a religious society in India, and we do these havan. So anybody who is doing this is creating an indoor pollution. We have to be careful now that all these, see what triggers that initial aspect, science doesn't know. So we have to be careful for all these. So it's a very valid point Prashant has brought out. I think because this is something which we may be doing it as matter of fact and never realizing that there are people who do probably you do this use of incense and humbug and all these things daily, daily morning practice. So we don't know 20 years down the line what is happening to the lungs. It could be, so we have to be careful. We have to take our measures, maybe air ventilation and all those things should be there so that we can at least reduce the impact. Right?
But जो ट्रेडिशनल पुजारी थे ना, somehow उनके अंदर के लंग फंक्शन इतने खराब नहीं होते थे, तो then I used to wonder why their lung functions are not so bad. And one reason, maybe a funny explanation that I have for that is they do a lot of yoga. Om Swaha, you can imagine that must be a part of yoga. Deep breathing exercises, etc. must be happening. That may be the reason why but then yes, they are at a higher risk for sure. And that too in a relatively poor ventilated space when they do that puja.
But isme the most important question, if somebody gets COPD now, so what's the treatment then? Can you give us an overview on that also?
So treatment is, there are multiple layers to treatment. Number one would be lifestyle changes. That's a part of treatment. So I want all my patients to do good steam inhalation. I want all of them to spend some time in sunlight. I want all of them to do some yoga, some breathing exercises, one part. I want them to take regular vaccination to prevent infections, second part. Third part comes is a pharmacotherapy. In pharmacotherapy, you've got fantastic inhalers, and I take pride in telling you that in my country, India, we've got one of the best combination inhalers available. We've got cheapest possible inhaler available. You can manage COPD treatment at few hundred rupees for months treatment, Only thing is they're compliant. They have to take this treatment regularly. I cannot cure you of COPD. I cannot cure you of diabetes. I cannot cure you of hypertension. I cannot cure you of arthritis. I cannot cure you of COPD. If you understand that well, if you take your treatment regularly, your symptoms can be under control, right? So you have treatment where you have tablets available, you have inhalers available. If they've got advanced disease, you've got nebulization available. These nebulizers now are portable nebulizers, such small nebulizer, battery operated. I can put 2 nebulizers in my pocket. That small is the machine now. When I was a student, it was this big a machine. And what noise? It used to make funny noise. Now there are absolutely noiseless small machines available. You can make a big difference in patient's life. Depending on what all associated disease. So your COPD patient is never going to be COPD alone. He's going to have blood pressure there, he's going to have diabetes there, he's going to have osteoporosis, he's going to have dyslipidemia, उसका cholesterol खराब है, मल्टीपल इश्यूज है क्योंकि वो 40, 50, 60 साल की उम्र में आता है. वो स्मोकिंग करता है. स्मोकिंग ना खाली आपके लंग को खराब करता है बट हार्ट को भी खराब करता है, ब्लड प्रेशर को भी खराब करता है. तो यू गॉट ट्रीटमेंट ऑफ ऑल दोज डिजीज. आप अगर आपको सही में अच्छा रहना है, खाली सीओपीडी ट्रीटमेंट इज नॉट गोना बी इनफ. आपका ब्लड प्रेशर भी कंट्रोल में होना चाहिए, आपका डायबिटीज़ भी कंट्रोल में होना चाहिए. भरत ने बोला सार्कोपीनिया, मसल्स भी कंट्रोल में होने चाहिए. All those things need to be managed well. So your COPD treatment will include all these factors.
But adding to this, if you can highlight on the lifestyle changes in terms which exercises, which food can also help.
I'll just add on to firstly something very very important is एक तो जो inhaler का myth है, it's very strange that even after 20 years हम ये बात करते हैं अभी भी कि लोगों को अभी भी ना hypertension is a chronic disease. कोई मना नहीं करता, रोज सुबह टप करके गोली खा लेता है ब्रेकफास्ट पे. जो गोली उसके पेट में जा रही है और उसके ब्लड में आ रही है और उसके फिर साइड इफेक्ट्स होने के चांसेस ज़्यादा हैं. एक इन्हेलर है जो कि आपकी लंग्स की प्रॉब्लम के लिए लंग्स में जा रहा है, ठीक है, उसकी एब्जॉर्प्शन ऑब्वियसली 1/10,000 होएगी, लेकिन उसको लेने में हमेशा हटकटाहट है ना. वो 20-22 साल के बाद भी आज भी हम यही पहली चीज़ जब हम कहते हैं यू नीड इनहेलर्स, द फर्स्ट थिंग इज यू शुड मतलब इफ समबडी शुड रिकॉर्ड दी इट्स अ नो आई डोंट हैव दैट मच डिजीज. आई सेड नो आई डोंट वांट यू टू हैव दैट मच डिजीज सो आई एम स्टार्टिंग द इनहेलर्स. नहीं कुछ और ऑप्शन नहीं है. सो इट इज़ वेरी इंपॉर्टेंट फॉर द पीपल लिसनिंग टू दिस पॉडकास्ट दैट फॉर लंग्स प्रॉब्लम inhalers are the step 1 therapy, right, when we are thinking of pharmacotherapy. So now, so that's, I think I just thought that is probably important to reiterate to. Definitely uptake has been very good now, but I think it's still a lot of long way to go that everyone understands. The costing has come down, so there is no reason for now people to think that it is unaffordable. So there are things have become much better with the as the industry has progressed. Now coming to what else we can think about, so lifestyle. So obviously, as we said, it's a multi-modality treatment. Prashant also said, and Dr. Agam also, that it's a multi-modality approach. So one of those approaches is pharmacotherapy, lifestyle changes. Obviously, smoking is a big no. And then you come to exercises. So there is something called as pulmonary rehabilitation. So there are people who are physiotherapists who are trained, or even doctor assistants who are trained in telling you how to breathe. So yoga is definitely almost a part of management, right? It is not the treatment. It is a composite way to add on to the pharmacotherapy. So because sometimes what happens, yoga is a very good modality to make a patient feel better. Probably 10 times better than what he is. There is no doubt. But the disease is not getting stalled. So you need to control both the things, the mental aspect and the physical aspect, right? And then coming to this nutrition. So this is something I'm pretty sure that every patient every person who is listening to this podcast who has ever had a COPD would want, kya khaun? Dahi khaun? Chawal khaun? Khaun? Nahi khaun? Kela khaun? So the idea is to have a healthy diet. And COPD per se, if you give me a minute, I think important is that, since he touched upon, as the disease progresses, you have more carbon dioxide production. So you would tend to have diet which have less chances of creating more carbon. So carbs, if you are taking, you have to reduce, or you take more complex carbs, right? You take more fiber, you take more protein, take a lot of fluid if it is not restricted because of some other disease. So you have to have something like 10, 12, 15 glasses a day. So if you look at this is what a balanced diet or a good healthy diet means. You don't want them to take a lot of sugary syrups, a lot of sugars, cold drinks, right? We don't want them to do that. So that's for everyone. So it is not different than having a healthy diet, but I think there is no one thing, because unlike asthma, where you may have some food allergies along with you, and you may need to actually cut down on, say, nuts or peanuts and stuffs, seafood, lot of allergies in asthma. It may not be the same for COPD, right? So, but you need a good balanced diet to actually take care of, because like muscles and all these things are getting involved. So you need all these things to be done.
Okay, and if I ask you, Dr. Chhajar, isme lot of people have started focusing on steam inhalation and having those kadha, like the herbs, using those herbs, like they want to make that as a daily practice. So how much that works actually?
So if you look at the medicine that we practice, I think I would like to summarize. I think my colleagues have really summarized it, and it couldn't have been put across in a much more simpler way. What are the important things that need to be practiced for management of COPD? I think I would not want to say what not to do, but I would say whatever points we have discussed are evidence-based. They are guidelines-based. There are global initiatives for COPD also. So all these points have been picked up with a lot of research, brainstorming, systematic reviews, controlled trials. Many things have gone, a lot of hard work has gone into this scientific data collection. So to summarize, I would say, let us focus more on the objective aspects as far as the COPD management is concerned. And I really want to thank my colleagues. They've really used very simple language to put across to the audience the important points. And I really hope and wish that the audience is able to adopt this and practice this.
Yeah, thank you so much. I mean, talking about this conversation and understanding in a very basic manner, I think everyone will agree, and I hope this podcast helps enough people so that they can at least go and get themselves checked. So thank you so much, doctors, for
take home message. एक बार गाड़ी कम चलाइए. Maybe anybody who is coughing, who's got breathlessness, who's sputum production, उसको motivate कीजिए lung function test करने के लिए. मे बी एनवायरनमेंट के बारे में थोड़ा ध्यान रखिए. मे बी घर के अंदर इंडोर पोल्यूशंस के ऊपर फोकस कीजिए. इट्स नॉट ओनली आउटडोर पोल्यूशन, इट कुड बी इंडोर पोल्यूशन एज वेल. खाने के ऊपर ध्यान दीजिए. एंड येस, वैक्सीनेशन, समहाउ वैक्सीनेशन मेरा बहुत कोर सब्जेक्ट रहा है. यानी मुझे लगता है कि हर एक COPD पेशेंट्स को जो गाइडलाइंस में मेंशन किया गया, वी हैव आवर ओन गाइडलाइंस, इंडियन गाइडलाइंस अवेलेबल है, जिसमें कहा गया है कि इन्फ्लुएंजा एंड निमोनिया 2 चीज़ों के वैक्सीन हर एक COPD पेशेंट को लेने चाहिए. तो अगर आप एटलीस्ट अपने फैमिली मेम्बर्स को, अपने मम्मी को, अपने पापा को, अपने दादाजी को, अगर उनको वैक्सीनेशन नहीं दिया गया है, अगर देते हैं, तो आई थिंक देन दिस टाइम इन्वेस्टमेंट goes in the right way. So I must thank you, Nona, for starting this particular initiative, doing this pains in organizing this program, and it was a wonderful experience.
Thank you. I think the whole idea about what I've loved is probably you have to learn about the disease. You learn about the disease, it will help you breathe better.
Yes, and lastly from my side, I think my colleagues have summarized it really very well. It's been a very efficient discussion, and I really want to take back to school. You know, somebody mentioned moral science, etc. I think we were taught a very important thing in school, which we somehow tend to forget in our journey towards the teenhood, towards the adulthood, and only at a particular time we realize it late. We realize we were taught early, we realize it late. Let us realize it today that health is wealth. Let's focus more on our health. Let us focus more on the respiratory health. Let us focus on health matters which can be taken in our hands in a very simple manner. So on the World COPD Day, please go and get your lung function done.
And I would really like to thank Zydus also for bringing such great initiatives and bringing you to us. So thank you so much, Zydus, also for amazing initiative, and breathe better every day. Thank you. Thank you so much.
Thank you.